So we are still in the topic of gram-positive cocci. We have discussed gram-positive cocci that grow in clusters. Now we will talk about those that form chains and sometimes pairs during growth. Okay. So the streptococci are a large and diverse group of bacteria, and so to classify them, we will need a number of systems to do so. We will not be able to talk about all the systems of classification, but we will discuss a few that will at least help us know the kind of bacteria we are dealing with that are relevant to medical practice. Okay? Now, based on observations made by microbiologists over time, we can use the following factors to classify streptococci into major categories. Okay? First, the colony morphology, particularly their hemolytic reactions and blood agar, and then the serologic specificity of cell wall antigens, particularly the group specific substance or Lancefield antigens, and also other features like their reactions and resistance to physical and chemical factors and ecologic factors. Okay, but these two are the most important. So streptococci stain readily with common dyes, showing that the cells are generally smaller and more ovoid in shape than staph. They are usually arranged in chains with oval cells touching end to end. Medically important strep are not acid fast, they do not form spores, and they are non motile. Some members form capsules made of polysaccharide complexes or hyaluronic acid. Streptococci are facultative anaerobes. Sheep blood agar is preferred because it satisfies the growth requirements and serves as an indicator for patterns of hemolysis. Now, the colonies are small and may be surrounded by a zone where the RBCs suspended in agar have been hemolyzed. So, when the zone is clear, this state is called beta hemolysis. Okay, so this happens when complete lysis of the RBCs occurs due to the production of either of two enzymes or hemolysins called streptolysin S or the oxygen labile streptolysin O. In group A strains, both are produced. Strains that lack streptolysin S are beta hemolytic only under aerobic conditions, no? Because the remaining streptolysin O is not active in the presence of oxygen. This is important to know because these strains would be missed if cultures were incubated only aerobically. But when the zone is hazy with a green discoloration of the agar, it is called alpha hemolysis. Okay, so this is a result of a partial or incomplete lysis of the RBCs in the agar. The green color is formed when hydrogen peroxide produced by the bacteria oxidizes hemoglobin, which is red, to biliverdin, which is green. If there is no hemolysis, it is called gamma hemolysis or simply non-hemolytic. Another system of classification was developed by Rebecca Lancefield, who demonstrated carbohydrate antigens in cell wall extracts of the beta hemolytic streptococci. This system divides strep isolates into different alphabetically named Lancefield groups, no? Group A, B, C, etc., based on the cell wall carbohydrates displayed by each species. So the serologic specificity of the group-specific carbohydrate is determined by an amino sugar. For example, for group A, this is rhamnose N-acetylglucosamine. For group B, rhamnose glucosamine polysaccharide. And for group C, rhamnose N-acetylgalactosamine. No? And the other groups, you can find it in the book. The groups are determined by different methods, right? It can be by precipitin tests with specific antisera or by immunofluorescence. But typing is usually done only for groups A, B, C, F, and G, which cause disease in humans and for which reagents are available. The antigenic specificity of capsular polysaccharides is also used to classify strep pneumoniae and the group B streptococci. We also classify streptococci using biochemical tests, no? Such as sugar fermentation reactions, tests for the presence of enzymes, and tests for susceptibility or resistance to certain chemical agents, no? Which are usually used to classify them after colony growth and hemolytic characteristics have been observed. They are also specially used for species that typically do not react with the commonly used antibody preparations, no? For the group specific or the Lancefield groups, like the Viridans strep, for example, which do not react with the antibodies used for the Lancefield classification. Okay. Now let's talk about specific species of Streptococci. Let's discuss the beta hemolytic Streptococci first. Again, remember these are strep that produce complete hemolysis. Okay. So first we have Streptococcus pyogenes. No, by far it's the most serious streptococcal pathogen of humans. It is the main representative of Group A beta hemolytic streptococci, no, or GABs. It is a relatively strict pathogen inhabiting in the throat, the nasopharynx, and occasionally the skin. The involvement of this species is partly because of the substantial array of surface antigens, toxins, and enzymes it can generate. So, like previously, let's discuss the important properties of the species. Okay. So first, the morphology. Individual cocci are spherical or ovoid and arranged in chains. Again, these are gram positive, but they can lose their blueness as they age. Most strains produce capsules made of hyaluronic acid. You will notice these capsules in very young cultures. Now, what are the capsules for? Actually, they are believed to help prevent phagocytosis of the bacteria. The capsule binds to hyaluronic acid binding protein CD44, which is present on epithelial cells. This binding induces disruption of intercellular junctions. Okay? The hyaluronic acid is chemically indistinguishable from the hyaluronic acid found in human tissues, no? Which is why it does not provoke an immune response from the host. But its actual role in disease is clouded by the fact that strains that have no capsule are still fully virulent. The cell wall is built on a peptidoglycan matrix that provides rigidity, no? Just like in other gram-positive bacteria. Within this matrix lies the group-specific carbohydrates. So the C carbohydrates, the specialized polysaccharides found on the surface of the cell wall, are the basis for the Lancefield group. Their apparent contribution to pathogenesis is to protect the strep from being dissolved by lysozyme defense of the host. A number of other molecules are also attached to the cell wall, no? Like the M protein and lipoteichoic acid, no? That are attached to the cell wall but extend beyond, even beyond the capsule, often in association with hair-like villi or fimbriae. The M protein is probably one, if not the most important virulence factor of strep pyogenes. It is a filamentous structure anchored to the cell membrane that penetrates and projects from the cell wall. When this is present, the bacterium is virulent. Okay, strep pyogenes that do not have M protein are not virulent. Take note also that there are more than 150 types of M protein. So a person can have repeated infections with strep pyogenes of different M types. The M protein itself is a fibrillar coiled coil molecule, no, with a structure similar to myosin. The carboxy end or the carboxy terminus is rooted in the peptidoglycan of the cell wall. This end is the conserved part and it is homologous in the different types. And the amino terminal regions extend out from the surface. The amino acid sequences at these amino terminal portions are the most variable, and they provide an antiphagocytic effect, and they also provide the serologic specificity of each type. No? Because this part is exposed, it is also the most available to immune surveillance. Now, the different types also contain epitopes that may stimulate the cross-reactive immune reactions, like the one you will see in rheumatic fever. Epitopes are the portion of the antigen where the antibody attaches to. Okay. There is also increasing evidence that some of the many known biologic functions, for example, antigenicity or the capacity to bind other molecules like fibrinogen and immunoglobulins, can be assigned to specific domains of the molecule, but we will not dwell on that for now. The lipoteichoic acid is important in the attachment of the strep to epithelial cells in the skin or in the pharynx. Now, the group A Streptococci also produce three important inflammation-related enzymes. So first, group A strep produce streptokinase or fibrinolysin. No? So this activates plasminogen to form plasmin, which dissolves fibrin in clots. This then allows the bacteria to escape from blood clots. And actually, because of this, streptokinase is also being used for treatment of pulmonary emboli and coronary artery and venous thrombosis, no? To lyse thrombi in the coronary arteries of heart attack patients, for example, because maybe the nurses here or the ones working in the hospital might have heard of streptokinase already. So this is actually the same streptokinase. Now, deoxyribonucleases or DNases degrade DNA and facilitate the spread of streptococci in tissue by liquefying exudates or pus. No? So they form pus. Hyaluronidase degrades hyaluronic acid, which, if you remember in histology, is the ground substance of subcutaneous or connective tissue. It is also called spreading factor because it facilitates the rapid spread of strep pyogenes in skin infections like cellulitis. Hyaluronidases are antigenic and specific for each bacterial or tissue source. So, after infection with hyaluronidase producing organisms, specific antibodies can actually be found in the serum. In addition to these enzymes, group A strep also produce toxins and hemolysins, which are very important contributors to their virulence. Okay, so you have the pyrogenic exotoxins, there are actually three antigenically distinct streptococcal pyrogenic exotoxins, no, or SPE. You have SPEA, SPEB, and SPEC. So SPEA is the toxin responsible for the streptococcal toxic shock syndrome. So it actually has the same mode of action like the staph TSST, or staphylococcal toxic shock syndrome, which means it is also a superantigen that causes the release of large amounts of cytokines from helper T cells and macrophages, and they cause shock and tissue injury. Okay, SPEC also contributes to the syndrome. SPEB is a potent protease that rapidly destroys tissues. So that's why it's also called the flesh-eating toxin. It also interferes with phagocytosis. The pyrogenic toxins A to C were also found to cause scarlet fever. So thus they are also called erythrogenic toxins. It was previously believed to be a separate toxin. These cause a bright red rash, which is typical of scarlet fever, no? And they also induce fever by acting on the temperature regulatory center. By the way, these exotoxins were found out to be encoded in a lysogenic phage. And then you also have the hemolysins. Okay, the group A strep produce the two hemolysins, streptolysin O and streptolysin S. They do not only lyse the membranes of RBCs, but they also damage other kinds of cells. So streptolysin O is hemolytically active in the reduced state, but it is rapidly inactivated by oxygen. So that's why I mentioned a little earlier that it is oxygen labile. This is responsible for some of the hemolysis that you will see when growth occurs in cuts that are deep into the agar in plates. Okay? This combines with an antibody that appears in patients after a strep infection called anti-streptolysin O, or ASO. Okay, you might have heard of ASO titer. This antibody blocks hemolysis by streptolysin O. So this is the basis for the ASO serum titer, which is a diagnostic test. So an ASO serum titer of more than 160 to 200 units is considered high. And this means that either the patient had a recent infection with Streptococcus pyogenes, or that the patient has a hypersensitivity reaction or an exaggerated immune response to strep pyogenes. Streptolysin S is the one responsible for the hemolytic zones around the colonies on the surface of the agar. But this is not antigenic though. Okay, so just so you don't get confused, streptolysin O is oxygen labile. Streptolysin S causes the hemolytic zones on the S surface of the agar, and it is elaborated in S serum. Okay? Again, most group A beta hemolytic strep produce both hemolysins. No? Only around 10% produce only one. Let's now discuss the disease spectrums of strep pyogenes. Okay, so first, strep pyogenes can cause local infection. No? The most common is the streptococcal sore throat, or strep throat, or pharyngitis. So the bacteria adheres to the pharyngeal epithelium through the lipoteichoic acid-covered fimbriae and the hyaluronic acid in strains with capsules. So streptococcal pharyngitis is characterized by throat pain and fever. It is also associated with lymphadenopathy or enlargement of lymph nodes, which can be tender or painful. You will also see on examination an inflamed throat and inflamed tonsils, and often yellowish exudate or pus formation. Some patients actually recover spontaneously in around 10 days, but rheumatic fever may occur, which we will discuss further in a moment. But some also may persist for weeks, no? And if untreated, they may extend to the middle ear to cause otitis media, or to the sinuses or sinusitis, to the mastoids or mastoiditis, or even the meninges or meningitis. If the patient is unable to swallow, this may indicate peritonsillar or retropharyngeal abscess formation. Strep pyogenes can also cause local infection of the superficial skin or pyoderma. In children, it is called impetigo. This is characterized by honey-colored crusted lesions, which are superficial vesicles whose eroded areas is covered with pus that later dry up to form the crusts. Take note that these are highly contagious and can be spread by direct contact after scratching the lesions, no? Or shared fomites like towels. Strep pyogenes can also cause invasive and rapidly spreading diseases. The bacteria can enter through a small wound or incision in the face or extremities and cause erysipelas. So upon entry, it eventually spreads to the dermis and subcutaneous tissues, causing edema and redness of the skin, no, near the portal of entry, and also fever and chills. The lesion spreads outward with a sharply demarcated margin. A similar invasion can also happen with the skin and subcutaneous tissues, no, with pain, tenderness, swelling, and redness, but without a distinct or marked margin on the skin, and the lesion is not raised. So this is cellulitis. Okay, so take note of the difference between erysipelas and cellulitis caused by strep. Okay. The infection can also be extensive with rapidly spreading necrosis of the skin, tissues, and fascia, causing gangrene or necrotizing fasciitis. If the bacteria enter the uterus after delivery, it causes endometritis and puerperal fever. And if the bacteria spread to the bloodstream, bacteremia, and then sepsis. The bacteria can also cause disease with the effect of the toxins they produce. So, if the strain causing disease in a patient with a strep throat or a skin or soft tissue infection produces the erythrogenic toxin, and the patient does not have antitoxin, scarlet fever may result. Okay, the pharyngitis becomes more severe with a characteristic strawberry tongue, and the patient develops a rash that appears on the trunk uh, after 24 hours of illness, no? And it spreads to involve the arms and legs. So this is important to ask when a patient comes to you complaining of fever and rash, because the fever and rash of strep pyogenes that causes scarlet fever has a distinct characteristic compared to the other fevers and rashes. Okay, so strains with protein M types 1, 3, 12, or 28, that make pyrogenic exotoxin A or B are associated with very severe infections that cause the streptococcal toxic shock syndrome. Okay, so this is characterized by shock, bacteremia, respiratory failure, and even multi organ failure. And the mortality rate is high at around 30%. Now, interestingly, even when an infection has resolved already, some patients develop nephritis or rheumatic fever around 1 to 4 weeks after the infection. So these diseases are called post-streptococcal glomerulonephritis or rheumatic fever. So it is important to take note that these diseases are actually not caused by the direct effect of bacteria, no, that may have disseminated, but are actually hypersensitivity responses of the body. So post-streptococcal glomerulonephritis usually follows skin infection, while rheumatic fever follows respiratory tract infection. The glomerulonephritis may be initiated by antigen-antibody complexes on the glomerular basement membrane. So what happens is complement is activated and C5a attracts neutrophils that secrete enzymes and damage the endothelium of the glomerular capillaries. The most striking clinical manifestations are hypertension, edema of the face, especially periorbital edema or around the eyes, and also edema of the ankles, no? And smoky urine due to blood and protein in the urine. The majority of cases clear up spontaneously and recover completely, but some develop chronic glomerulonephritis, eventually kidney failure, and some even die. Rheumatic fever is the most serious complication, okay, because it causes carditis or damage to heart muscle and to the heart valves. No? And if you can remember, damage to heart muscle and tissues are permanent, di ba? So it also affects joints, no, causing arthritis, and brain tissue causing chorea or uncontrollable spasms of the limbs or the face. So again, this usually follows streptococcal throat infection, but not skin infections. So what actually happens is that there is an immunological cross-reaction between antibodies formed against the M proteins of strep pyogenes and the proteins on the surface of the joint, the heart, and the brain tissue. So in other words, the patient's own antibodies are damaging the body's own tissues because the tissues look like the strep bacteria that the antibodies are supposed to go against, no? Meaning it is an autoimmune disease. This is exacerbated by strep infections and usually prevented by treating the strep infection within 8 days of onset. Don't worry, you will have a separate module on these diseases. Okay? Now, how do we diagnose streptococcal infections? So, specimens used can be throat swabs, pus, CSF or other body fluids, or blood, depending on the nature of the infection. For pharyngeal swabs, gram staining is not really useful because Viridans strep, which are normal flora, cannot be distinguished from the pathogenic strep pyogenes. No? Although specimens from the skin lesions or wounds that show streptococci, these are diagnostic. Culture on blood agar plates show beta hemolytic colonies. No? In another textbook, sheep blood agar plates incubated anaerobically are considered to give the best yield, considering the presence of the oxygen labile streptolysin. Or you could also slice into the agar, as oxygen does not usually penetrate into the medium. In smaller laboratories, another way is demonstrating susceptibility or resistance to bacitracin. Okay, so bacitracin susceptibility predicts group A strep, but many commercial kits are already available for rapid detection of group A strep antigen, no? Like those that test for the presence of group A specific antigen, and also by PYR test, and the results are even available in a few minutes to a few hours, and also they are even more sensitive than culture methods. Okay. All strep pyogenes are highly susceptible to penicillin G, no, which is the antibiotic of choice. Macrolides like erythromycin or clindamycin can be used for those who are allergic to penicillins, but resistance have been observed already. No? Take note that antibiotics have no effect on established glomerulonephritis and rheumatic fever. Okay, but adequate treatment must be made, especially within 8 to 10 days of the onset of the strep pharyngitis, to remove the antigenic stimulus that may cause the rheumatic fever later. By the way, resistance against strep diseases is M type specific, no? Meaning a patient who has recovered from infection by one group A strep M type is relatively immune to reinfection by the same type, no? But still fully susceptible to infection by another M type. And there are how many M types again? More than 150. So much for group A strep. Let's go to group B. So Streptococcus agalactiae. So take note that these are still beta hemolytic streptococci, okay? And they produce zones of hemolysis. So they hydrolyze sodium hippurate and produce a positive response in the CAMP test or CAMP test, or Christie-Atkins-Munch-Peterson test. Contrary to group A strep, group B strep are bacitracin resistant, and they are actually part of the normal flora of the vagina and lower gastrointestinal tract in some women. But during pregnancy and childbirth, this bacteria can gain access to the amniotic fluid or colonize the newborn as it passes through the vaginal canal. Okay? Group B strep produce disease in around 2% of these events. If the baby gets infected during the first few days until around 1 month of life, infection can present as neonatal sepsis, meningitis, or respiratory distress syndrome. The baby will have fever, vomiting, and seizures. Sadly, around 20% will have long-term brain damage. And the risk is even higher when factors are present that either decrease the baby's innate resistance, like, for example, prematurity, or increase the chances of transmission, like rupture of membranes for 18 hours or more before actual delivery. No? So, in cases like this, it is prudent for the physician to make sure to cover for these organisms before and after delivery. Actually, there are already guidelines and recommendations that OBGYNs follow, like screening of pregnant women even before delivery, and IV penicillin or ampicillin 4 hours prior to delivery for those with colonization, no? And who are in labor to prevent the colonization of the baby during delivery. And two more populations who are at high risk of infection are the elderly and those who are immunocompromised. For treatment, penicillin is still the drug of choice. Other pyogenic streptococci occasionally produce various respiratory, skin, wound, soft tissue, and genital infections, no? Which may resemble those caused by Group A and Group B strep. Although a few foodborne outbreaks of pharyngitis have been linked to Groups C and Group G strep, their role as a cause of everyday sore throats is not established. They often look like Group A strep on blood agar, and they are also beta hemolytic. They can be identified by using anti-sera specific for Group C and G, respectively. The Group D Streptococci have undergone recent taxonomic changes. There are 8 species in this group, and many of these do not actually cause infections in humans, no? The most important is the Strep bovis group, which are classified to biotypes, no, following the old classification, but which is still used for epidemiological purposes, and the recent classification into 4 DNA clusters. One important species is Strep Galliolyticus, subspecies Galliolyticus under DNA cluster 2, no, which ferment mannitol and can cause endocarditis and is also associated with colon cancer. But actually, the taxonomists themselves seem to be confused, no? So we will not join them in the confusion, okay? It suffices us to know that they are non-hemolytic or technically gamma hemolytic and PYR negative. They grow in the presence of bile and they hydrolyze esculin, but they do not grow in 6.5% sodium chloride solution. They are also believed to be part of the normal enteric microbiota of humans and animals. Another important strep to know is the Streptococcus pneumoniae. No? These are also called pneumococci. They are a member of the Streptomyces group. These present as gram-positive diplococci, okay, or in pairs, which are lancet-shaped, but they can also be arranged in chains. They are alpha hemolytic and bile and optocin sensitive. Another important property for identification of strep pneumoniae is the quelling or swelling reaction of the capsule when mixed with an anti-serum. So they have a polysaccharide capsule, no, that allows typing with a specific anti-serum. The capsule is responsible for the virulence of the bacteria. It prevents or delays phagocytosis of host immune cells. Antibodies formed against the specific polysaccharides protects against infection. No? This is important to know because the pneumococcal vaccine developed for this purpose is now pushed as a part of the expanded program on immunization by the DOH, no, for children. So they are normal inhabitants of the upper respiratory tract, but they can cause pneumonia, sinusitis, otitis, bronchitis, bacteremia, meningitis, peritonitis, and other infections. Pneumococci have different types based on the capsular polysaccharide, no? Of which there are 91 types identified. In adults, types 1 through 8 are responsible for causing majority of pneumococcal pneumonia cases, no? And more than half of all deaths. In children, the most common are type 6, 14, 19, and 23. So it is the most common cause of community-acquired pneumonia or CAP. Now, we mentioned earlier that the bacteria are actually normal residents of the upper respiratory tract, di ba? Meaning the normal upper respiratory mucosa has natural resistance against the pneumococci. But infection happens when a number of factors lower this resistance. For example, damage of the mucosa due to a viral infection, or damage due to hypersensitivity or allergic reactions, no? Causing abnormal accumulation of mucus or disturbance in the mucociliary physiology, or also depression of phagocytic activity in the area, and depression of the cough reflex due to alcohol or drug intoxication. So this can cause aspiration of foreign material. Okay, and also malnutrition. Pneumococcal pneumonia usually presents with fever, chills, and pleural pain. Sputum production is purulent with blood, no, or rusty colored sputum. On X-ray, consolidation may be seen on the right middle lobe and the left lower lobe. Pneumococci also frequently involves the sinuses, no, causing sinusitis, and the middle ear, causing otitis media, and even the triad of meningitis, endocarditis, and septic arthritis, which is a result of bacteremia from the pneumonia. Okay? Strep pneumoniae is the most common cause of otitis media and mastoiditis in children. And strep pneumoniae is also the most common cause of meningitis in adults. Now, complications can be prevented by early treatment. Strep pneumoniae are now more and more resistant to penicillin. That's why we cannot use it in low doses anymore. No? So high dose penicillin G still appears to be effective, but the uncertainty has caused a shift toward third generation cephalosporins like ceftriaxone or cefotaxime. Patients with meningitis are usually treated with a high dose of an active third gen cephalosporin plus vancomycin. To be sure, susceptibility testing is performed. No, this is the best thing to do. Response to treatment is actually quite dramatic. No, there is reduction in fever, in the respiratory rate, and the cough in 12 to 24 hours after starting treatment. But the chest X-ray may return back to normal only after several weeks pa. For prevention, polyvalent vaccines are available for immunization. In the Philippines, the PCV13 is used. Now let's talk about the Viridans group. So one textbook says that it comprises all alpha hemolytic streptococci that remain after the criteria for defining pyogenic streptococci and pneumococci have been applied, but they may also be non-hemolytic. Growth is not inhibited by optosine, and colonies are not soluble in bile. So this includes the strep mutans group, strep mitis, Strep anginosus, Strep salivarius, and the Strep bovis group. Okay. Now, the Viridan Streptococci are the most prevalent members of the normal flora of the upper respiratory tract, no? And they are important for the healthy state of the mucous membranes there. They may reach the bloodstream due to trauma and become the main cause of endocarditis on abnormal heart valves. Some contribute also to the production of dental caries, no? Particularly the Streptococcus mutans. And lastly, the Enterococci. Actually, these bacteria have the group D, group specific substance. No? That's why they were previously classified as group D, Streptococci. They are usually non-hemolytic and sometimes alpha hemolytic. They are PYR positive. They grow in the presence of bile and hydrolyzed esculin, and they grow well in 6.5% sodium chloride solution, no? Contrary to the other group D, strep. Enterococci are commensals and are part of the normal enteric microbiota. And the two most common species are Enterococcus faecalis and Enterococcus faecium. Infections are usually due to translocation of the bacteria, no, from their normal habitat. The most common is the urinary tract, no, usually due to instrumentation, insertion of urinary catheters, and structural abnormalities in the genitourinary tract. It can also cause meningitis and bacteremia in neonates, typically from vaginal delivery. Interestingly, Enterococci are highly resistant to a number of antibiotics, no? To beta-lactams, cephalosporins, and aminoglycosides. No? Despite these, ampicillin is still the drug of choice for most UTIs and minor soft tissue infections. For more severe infections, particularly endocarditis, a combination of penicillin and an aminoglycoside is usually used. So again, susceptibility testing is key. So to summarize, streptococci can be classified according to their hemolytic reaction and their Lancefield antigen groups. Okay, so complete hemolysis and culture are found in beta hemolytic streptococci. If they are bacitracin sensitive or susceptible, they are group A. The bacitracin resistant groups that are CAMP factor positive are group B. Group C and G are CAMP factor negative strep that are also bacitracin resistant. For the alpha hemolytic strep and sometimes the non-hemolytic, the strep pneumoniae are optocin sensitive, and group D strep and the Viridan strep are optocin resistant. All right.